Hello everyone, my name is Parnian. I'm a PhD candidate at Concordia University, and on behalf of my collaborators from Concordia University, University of Toronto, McGill University, and Sunnybrook Hospital at Toronto, I'm going to present our study on COVID-19 diagnosis entitled Hybrid Deep Learning Model for Diagnosis of COVID-19 using CT scans and clinical or demographic data. First, I will talk about the motivation and intuition behind our study. I will talk about our contributions and the dataset we used to run our experiments. I will talk about the framework we developed and the results we got. At the end of the presentation, I will conclude the study and give you some references to follow our study. So first of all, as you all know, COVID-19 disease is a crisis of the recent years, and it is affecting all of our lives from different aspects. Early diagnosis of this disease is of high importance as it can help us to isolate the infected cases and prevent the transmission to other people, and also to plan the treatment for infected cases. So it means that we have to distinguish COVID-19 patients from non-COVID ones, which can be either completely healthy people or people infected with pneumonia. The PCR test is the gold standard for COVID-19 diagnosis. However, it suffers from low sensitivity, which means that we can miss lots of positive cases. And it is also time consuming, which means it can take up to 3 days to get the results from a test. An alternative for COVID-19 diagnosis is medical imaging using either X-ray or CT scans. And this is because COVID-19 shows specific manifestations in medical images that can help with diagnosing and also assessing the severity of the disease. The difference between X-ray images and chest CT scans is that CT scans are 3D images, so that they can give us more informative and useful features for diagnosis. But using CT scans has its own specific challenges. First of all, it's a 3D data, which means it is more difficult to process compared to single chest radiographs. And also, we are limited to small data sets and limited labels and annotations provided by experts. Also, COVID-19 findings in medical images can overlap with findings from pneumonia cases. And the distinctive distribution of COVID-19 throughout the CT scans makes it difficult to find a relation with other instances of the image. This figure here shows a case that has evidence of infection and a case without evidence of infection. So what we did was to propose a hybrid model, which is built upon our proposed CT-CAPS model. CT-CAPS model uses segmented line regions and removes unimportant components and artifacts in a CT image and represent a large volumetric CT scan by small feature maps. Also, we incorporated patients' clinical and demographic data into the CT-CAPS framework. And the proposed hybrid model resembles what the radiologists actually do for COVID-19 diagnosis. The dataset we use consists of 171 COVID-19, 60 CAP, and 76 normal cases. For these cases, we got the patient level labels, but also for 55 COVID-19 and 25 cases, we were able to obtain slice level labels from experts, which means that we know which slices of these cases show evidence of infection and which ones do not. This figure here shows the pipeline of our hybrid model. The input to this model are volumetric CT scans whose lines are first segmented, and the images are fed through several layers of convolutional capsule pooling and fully connected to get the probability of COVID-19 being present from the CT scans. This probability is then merged with some clinical data such as gender, age, weight, and 13 symptoms that are finally fed to a random forest classifier to make the final decision. So as I mentioned, the probability of the COVID-19 class being present from the CT caps is merged with clinical data. This clinical data is gender, age, weight, and 13 symptoms, for example, cough, shortness of breath, or chest pain. We encoded the gender and the 13 symptoms in 0 and 1. For example, in the case of gender, 1 represents male and 0 represents female. And if S1 represents cough and it gets the value of 1, it means that the patient shows the symptoms of cough. The output of the final RF classifier is the probability of COVID-19 or the patient being diagnosed with diseases other than COVID. The first table here shows the results we got from the proposed hybrid model, which shows it can outperform the previously proposed CT caps in terms of accuracy, sensitivity, and specificity. It can also outperform a hybrid model that do not contain lung segmentation, a hybrid CNN, and a hybrid ResNet 50. In table 2, we show the features that were most important and contributing the most to the final random forest classifier. These features are the output from CT caps, age, weight, cough, and fever. This figure here shows one of the trees obtained from the random forest classifier, and by using features from the CT caps and also the clinical and demographic data, we can follow the path in the tree and find out if the patient has COVID-19 or not. So in conclusion, we propose a hybrid model that incorporates patients' clinical or demographic data into a previously proposed CT caps model that uses only CT scans. We showed that adding such informative data to the model can increase the performance and also the explainability of the model. We showed that the output of the CT caps, age, weight, cough, and fever are the most influential features on the output of the RF classifier. And we also showed that even self-reported symptoms can be beneficial and useful to the diagnosis of COVID-19 based on the model we proposed. The first reference here is our first study on COVID-19 diagnosis, which uses X-ray images and is published in pattern recognition letters. The second reference is the COVID CTMD dataset we used to elaborate on the framework we developed. This research is published in Nature Scientific Data. The third reference is the CT caps model upon which our hybrid model was built. And thank you for your attention, and please forward your questions to my email. Thank you.